Hello, everybody. Greetings to all. We start the second day of our ALAT Congress. And what better way to begin this day with a symposium with the representative of our sister societies. I would like to introduce our speakers. The time for questions will be at the end of the session. So Dr. Mark Cohen is the director, the president of ALAT. He's gonna be with us to coordinate this session. And the speakers are David T. Lam, he's over there. You can say hi, David.
Hello.
He's the professor assistant of the Department of Medicine in La Universidad de Hong Kong. He represents APSR. Doctora Clarissa Baldotto from Brazil. She's oncology and es la directora ejecutiva del grupo brasileño de oncología torácica.
Hi, hello.
Thank you, Clarissa.
Nice to be here.
Sebastián Lamotte from Argentina and our representative from ALAT. Él es director de oncología del departamento de ALAT y neumólogo clínico en el Hospital de Neuquén en Argentina. Por último, quiero presentar a la doctora Patricia Rivera, que se está incorporando en este momento. Ella representa Affairs y es profesora de medicina, directora de los programas multidisciplinarios de oncología torácica y de screening de cáncer de pulmón, y es vicepresidente de ATS. Ella trabaja actualmente en la Universidad de North Carolina. Así, sin más preámbulos, invito al doctor Lam para comenzar su presentación. Le pido al resto de los participantes que apaguen sus cámaras y damos comienzo a esta sesión. Muchas gracias a todos.
And honored to be invited to attend this Congress of ALAT this year, and representing the Asian Pacific Society of Respirology to share with you my topic on early detection and screening for lung cancer. So lung cancer is not a new topic. Indeed, there were earlier trials in Asia before, even before the year 2000, when you can see a lot of the trials initially has been attempted before the year 2000. But indeed, at that time, without much success, because the protocol was not that well defined. And at that time, you may see the tool for screening is just ordinary CT. It's not yet the low-dose CT that we see nowadays. Until later, we have many big trials coming. At that time, you can see from Europe mainly, and including the Nelson trial that has been launched in the early phase just after year 2000, and you probably have heard about the latest results recently. Until we have about 10 years ago, we have the National Lung Screening Trial that we all know that it is the first almost the first one in North America that include randomization of recruited subjects into a CT arm and at the same time an X-ray arm to follow them for the results of lung screening. And they targeted subjects who are aged 55 to 74 with a heavy smoking history. And the trial was quite successful in the sense that it has got a high degree of subject adherence, and the rate of positive screening was indeed about 24% in the CT group compared to about 7% in the X-ray group. But unfortunately, more than 90% in each group was later proven to have false positives. So this is a high false positive rate. But indeed, the trial has another success in that it is the first time that lung screening using low-dose CT in the targeted group of heavy smokers of the appropriate age range has been shown to improve mortality from lung cancer by reduction of almost 20% compared to the group that is on the X-ray screening arm. So it is the result of that national lung screening trial in North America that later it is recommended in the United States that annual low-dose CT screening will be useful for subjects who are 55 to 79 years with a heavy smoking history of more than 30 pack years, and they in general should be healthy and could be candidates for surgery. That's the recommended criteria for screening that most lung screening program in other countries has adopted similar ones, including later in this part of Latin America, that's Brazil, that a subsequent trial with similar screening criteria or recruitment criteria similar to the national lung screening trial that has been done initially with the first one as a single arm, single group screening with low-dose CT that has found about 3.2% of lung cancer in heavy smokers. And this was followed by another effort with the second part of the trial, where it has expanded into 6 centers in Brazil with more smokers included, with a relatively similar indexes of screening results of about 2% of lung cancer screened in the target groups of subjects. So a lot of trials has been done in the smokers, but there are still some questions that remain unanswered from the previous clinical trials, that whether smokers are the only group that would be benefit from screening. And we are faced with a lot of issues with the management of low-dose CT detected lung nodules. And we need to have a definitive diagnosis of suspicious lesions, especially lung nodules. And at the same time, we need to face with the issues of the identification of many non-cancer pulmonary diseases, that is mainly what we call the byproducts of lung screening with low-dose CT. So looking back at the global burden of lung cancer, indeed, you can see if we separate lung cancer cases into men and women, it appears that although the lung cancer statistics or the lung cancer numbers or mortality appears to be reducing in the men group, especially those in the relatively high income country, which is not the same as in relatively low income country, there is a consistent trend of increase in female patients with lung cancer, no matter what we're talking about relatively low income countries or relatively high income countries. So it appears that, and a lot of the times, these female patients with lung cancers were smokers, non-smokers. So it appears that patients who are mild, most of the time smokers, and people who are females who are most of the time non-smokers, although they still both have lung cancer, it appears that they may be different kinds of diseases. So it has been shown before that low-dose CT can reduce lung cancer mortality in heavy smokers, but it appears that lung cancer in smokers and never smokers could be two different diseases. And the incidence of lung cancer in never smokers is increasing globally, while previous studies have shown benefits of screening in lung cancer mortality in smokers. So what about the increasing incidence of lung cancer in female patients, and especially those non-smoker patients? Could screening, especially low-dose CT screening, be useful? And when we look at the previous situation, when we don't have lung cancer screening program, a lot of the times, if we detect the lung cancer, just by their presentation, most lung cancer patients will present at a late stage. And with such presentation in later stage, a lot of the time it will be associated with a problem in the reduced survival in these groups of patients. Looking at the situation and in different parts of the world, it appears that in patients who are actually female with lung cancers, most of them are actually not smokers. And in the part of the world that I live in, that's in Asia, there are also concerns that the incidence of lung cancer actually may be associated with the high index of air pollution around the area. So different location may have slightly different risk factors for the development of lung cancer. And it has been shown that lung screening may shift the detection of lung cancer disease from an relatively late stage towards earlier stage, as shown by the figures here, that in general, if we try to wait for the patients to present with symptoms, a lot of the times in the general population, most of the patients will present with a low proportion of early stage disease. But while with screening, a lot of the patients could be identified at an earlier stage, preferably in the stage 1 when it is still curable and resectable. So a recent trial is ongoing in Taiwan with my colleagues from the Yang's group that is carried out previously, recruiting subjects who are non-smokers with the age of 55 to 75 with certain lung cancer risks like family history, like previous lung disease, or cooking. They screen with an X-ray first, and if there is nothing on the X-ray, they will proceed to low-dose CT scan of the chest. And it has been shown that the interim results has been reported on previous World Lung Cancer Congress, that the detection rate for lung cancer, especially for those early detection in early stage, resectable stage, stage 1, is variable from 2 to 3% for patients, for subjects who have or have not got any family history. And this is even higher than the previous trials in smokers. Talking so much about lung cancer, we are proceeding to screening for both heavy smokers as well as going into non-smokers in certain parts of the world where we have a high prevalence of non-smokers with lung cancer. Screening is not diagnostic of lung cancer. It gives a lot of lung nodules of various sizes, shapes, composition, and numbers, and together with a lot of non-cancer lung diseases that are screened out as a byproduct of screening. And these lung nodules comes with different context, different texture, and different shapes. They can be solid, although most of them solid, some of them will be non-solid, and they have different implications. With such uncertainty, a lot of the times we have to go with further invasive investigations with needle biopsy of the nodules, and this comes not without complications. So there are implications with such screening. So not only are we faced with these issues of potentially invasive investigations and complications, follow-up is of utmost importance for the success of a lung screening program. Just to share with you, one case that I recently seen in my clinic is that 2 years ago, he joined the screening program with the finding of a lung nodule that is already suspicious by features, but unfortunately, in the subsequent months, he left our locality to move to another area because of the COVID situation. And then when he comes back 2 years later, the mass actually has gone up to become larger and is subsequently diagnosed to have lung cancer. So appropriate follow-up is important. Not only are we picking up lung nodules on screening, a lot of them are being picked up incidentally in the general population when we do more and more CT because of various reasons. And a lot of them are just incidentally picked up. And we now have established, more or less established models to try to predict the risks of these identified nodules, taking into consideration the different clinical parameters like age, gender, family history of lung cancer, and the nodular size and the nodule characteristics. And there are different guidelines from different societies advising on the management of these incidentally picked up pulmonary nodules. The most well-known one will be the criteria from the Freshness Society and the lung rats from the American College of Radiology. And you can see, sorry for the very busy diagram here, but just to show you that one of the recommendations from Freshness Society is based on the size of the nodules together with the whether they're coming from high risk or low risk individual, and whether the characteristics of the nodules are subsolid or ground glass, to recommend on the different pattern of follow-up that is necessary, or immediate biopsy that is necessary for those that are suspicious of actually a high risk of lung cancer. And a lot of the times, a follow-up of these incidentally picked up nodules, 2 years, 1 to 2 years down the road, there is also a chance of early detection of these lung cancer in the early stage. Hopefully, just like screening, there will be a stage shift towards early detection of lung cancer. So nowadays, in the United States, for example, there is a proposal to have both lung screening program and lung nodule program to run side by side in order for a better coverage of the patient populations, including non-smokers, in order to try to get these lung nodules with high malignant risks to be detected early, for lung cancer to be detected in the early stage. And this calls for a multidisciplinary approach, usually led by pulmonologists, in the management of these incidentally picked up pulmonary nodule. So in summary, for these incidental pulmonary nodule, and it is necessary to ensure timely and appropriate investigation and appropriate follow-up to enhance the early detection of lung cancer. And this will complement lung screening program. And but there are remaining questions as to what will be the appropriate time for further investigation and how to enhance the adherence to surveillance. And there are always the discussion on the role of artificial intelligence on image diagnostics, and also the role of biomarkers in early detection of lung cancer. So talking about biomarkers in lung cancer, or for early detection or screening, we are not yet at the moment, but we are trying our efforts to identify any biomarkers that could be useful in predicting lung cancer. And examples of these tumor markers that we have been using day in and out in our clinics, and also we will be exploring with new biomarkers, but we are not putting them into a screening program yet, because it would be better if we can try to verify the presence of these serum markers and the usefulness of these markers, for example, in different stages of lung cancer, before we can put them into biomarkers trial or even lung screening program. And we are working towards that, and hopefully with the combination of clinical characteristics, we will achieve better model for the use of these biomarkers in the early identification and prediction of lung cancer in the future. Hopefully, by that time, we'll be able to share with you more. So today, with this occasion, I hope I've shared with you, given the different epidemiology and the molecular profiles of lung cancer in different parts of the world, further randomized clinical controlled trials in screening or early detection of lung cancer is indeed needed in order for us to know the at-risk population to target at different populations. Low-dose CT is now an established and useful tool for lung screening and early lung cancer detection, but a lot of questions remain as to whether there is a true lung cancer mortality reduction in different patient population characteristics, and whether how we can reduce the magnitude of overdiagnosis, and post-screening evaluation and management support is essential. And lung cancer screen risk assessment model should be taken into account all those different features, including age, smoking history, family history, as well as other clinical characteristics to achieve a better risk prediction modeling. Still, I would say lung cancer screening is not diagnosis, and prevention is always better than treatment. So smoking cessation is still the priority in lung cancer early detection and treatment. So I hope, thank you again for inviting me to this talk in this Congress. Thank you very much for your attention.
Hello, good morning, good afternoon. I don't know, depends on the place. My name is Clarissa Baldo, so I work here in Brazil as a thoracic oncology. And my job here will be to cover the subject of mutations in lung cancer, to whom, and what kind of mutations you should order. I apologize because some of my slides are in Portuguese, but the data are all in English because I wasn't sure about the language I should use in the presentation, but I think you will understand what I mean with the pictures. The first concept, target therapy is one of the greatest advances in lung cancer treatment in the last years in the oncology field, actually. But I want to clarify that when we talk about target therapy, doesn't mean that all target drugs are used as target therapies. This is very important for our presentation. We have a lot of target drugs that don't have a defined biomarker that works improving the outcomes of the patient. It's only when you get the right biomarker and you can find it easily in the patients that we are talking about the target therapy. And when we are deciding about giving a target, of offering target therapy for our patients, what we really want is to improve response rate, of course, but also overall survival, disease-free survival, and the common endpoints that we get from chemotherapy and other strategies for treatment. And this is also a very important concept because you see that when we discuss target therapy in lung cancer, sometimes we are having drugs approved only based in response rate. And it seems to work with a lot of strategies with different drugs, but maybe it's not going to work with all target drugs that we are developing in the next future. And this kind of discussion becomes more and more important when we are talking about adjuvant therapy. That is a new scenario that's coming up this next year. But going back to the pie that we are all now we see in all presentations when we are talking about target therapy, this is maybe one of the most recent pies because it's changing every day. Talking about all the different targets that we have, the different mutations and molecular alterations that we have in non-small cell lung cancer. And what I want to call your attention now is that we have more patients that have a molecular alteration identified than patients that don't have it. It was very different in the past when we had 20-30% of the patients where we could identify a molecular alteration that was targetable. It's becoming more common to have patients that harbor this kind of molecular alteration when we can have a specific treatment for them. So the first question we have to ask, and it's the main point of my presentation, is when we have to look for a target in non-small cell lung cancer patients. So we always have to ask if the patient should be tested for a molecular alteration. But especially if we are talking about non-squamous lung cancer, non-squamous, and squamous patients that are non-smokers. In this population, we always have to test before starting treatment, because the mutational status of the patient is going to define not only if the patient deserves a target therapy, but also if we are going to be able to use and indicate immunotherapy for this patient. And I'm not talking about immunotherapy today. It's not the topic of the presentation, but I want to remind you that PD-L1 is also an important biomarker that we should order for these patients, but usually after we have the mutational status. So the next question will be, where should we look for the target? So as I mentioned before, we always have to ask, and it's an obligation to look for the target in all patients that has a non-squamous histology and adenocarcinoma, but all non-squamous histology, they should be tested. In advanced disease, and now what is new, we also have to test patients for when they have initial disease, especially if it is more than 1B, the stage of the patient, after he was, of course, submitted to surgery. This is new. I don't know if it's approved in all of the countries here in Latin America, but in Brazil, it was recently approved, a target therapy as adjuvant treatment. So now we have to test at least for EGFR and now maybe PD-L1 patients that has been submitted to a patient that has been submitted to surgery and has initial disease. And this kind of test is not dependent on sex or smoking status. This in the past was very common. We heard a lot of oncologists say, no, I'm only testing non-smoker patients, I'm only testing female patients, and this is not right. We should test all the patients independently of the sex or smoking status. And we also should consider testing patients with squamous or even other histologies if they are non-smokers. Where should we look for the targets? So there are a lot of different targets, as I showed before. I'm going to create kind of scale where what are the most important targets. But another important question is the kind of test we're going to order. And there are a lot of difference between the different tests. When you're talking about, for instance, EGFR, we can go for PCR or we can go for a next generation sequence. When we're talking about ALK tests, it's also available immunohistochemistry as we have it for ROS1. But when you're talking ROS1, we have to confirm once you have a positive immunohistochemistry. So it's very important. What I want to bring out with this slide is that it's very important that you consider the type of test that's being performed in your center, because sometimes there are differences in sensitivity, differences in specificity of the tests. We now we prefer using an NGS when it's available, because you have more tests performed with the same amount of tissue and material, but of course it's not available everywhere. And we also have a concern about time. Time is very important because, as I mentioned before, we need to wait for the results of these tests in order to start the treatment. And it's not every time that it's possible to wait like 2 weeks or 3 weeks in order to start treatment. So for instance, in our center, in our site, we have a strategy that we split the tissue when the biopsy is performed, and we send the first part of the tissue for analysis, the first analysis in immunohistochemistry, and we perform a PCR, an ideal PCR for EGFR and ALK, BROS, MET, RET, and TRAC. And then we send another part of the sample for an NGS platform, like for instance, Foundation One, or another one that is available, and it can take like up to 3 weeks to get the results, but we have in 48 hours the first results of our test. So the message here is that you should design a strategy in your center, in your institution, in order to decide what is faster and what is more sensitive, that gets the best sensitivity and specificity for the test you want to order for your patient. Another important subject that's coming up is if you can use liquid biopsy. I'm not going to go through this topic. I just want to remind you that liquid biopsy is becoming more and more common. And we have now a lot of trials that are using liquid biopsy as a strategy to detect this kind of targets. It seems that has a very good sensitivity and specificity, and it's very easy to get from the patient, especially when we're talking about resistance. I believe that liquid biopsy is going to become a very important ally to us. Another important question is how are you looking for the target? As I mentioned before, the type of the test, but not only the type of the test, but also the sample we are using. So I'm going to go very quickly through this slide. It's just a reminder that when we talk about, for instance, a sputum cytology, it's very, very different from material coming, sample coming from surgical resection. So when we are planning the type of biopsy of the patients, we have to think about this kind of problems that we can experience with some types of samples. Of course, we prefer to go non-invasive or the least invasive as possible with the patient, but it's not always possible to get a good sample when you decide to perform a cytology, for instance. So it's very important that pneumologists, surgeons, and oncologists, pathologists, they have to be together in this part of the decision, because in this moment is very important for the patient. If you have to rebiopsy a patient or wait for more tests, it's gonna delay the treatment of the patient. And when I talk about this, of course, I'm talking also about the phases of the pathology analysis, and the pathologists, they have to work together with us, because these three phases, the pre-analytical phase, the analytical phase, and the post-analytical phase, they can influence in the results of the test. So when I look for the target, I have to be all the time worried about the technique that my pathologist using, if it's gonna give me good results for the tests I need to have. So moving on to the recommended biomarkers, it can differ from country to country, from institution to institution. IASC has published this recommendation in 2018, where they recommend always EGFR, AL, ROS, BRAF, that could be optional by then. And EGFR T790M was recommended at that time where we didn't have the third generation EGFR inhibitors available, but they also gave an option of KRAS, HER2, RET, and MET. It is changing over time because we have new drugs, a lot of new drugs available. If you look through NCCN recommendations, there's another guideline that a lot of oncologists use a lot all over the world. We can see that they recommend more tests. They recommend EGFR, but not only EGFR sensitive mutations like EGFR exon 19 deletion or exon 21 mutation, but also exon 20 insertion mutation, KRAS G12C, ALK, ROS, BRAF, V600E, and TRK, MET, especially exon 14 skipping mutation, and RET. These are the recommendations. I think we should look at our country, what kind of drugs we have available, but if it's possible, performing an NGS and having all this information, I think it's my preferred option too. So I'm gonna, in the next 10 minutes, go through this, I think the main targets we have. And this picture illustrates like the targets we have more clinical trials, phase 3 clinical trials, more robust data. Through the other ones that we have data, we have drugs approved, but not so robust evidence based on phase 3 trials. So I'm going to talk a little bit about the options for EGFR, ALK, and these two, I think we cannot start a treatment for lung cancer patients without having this kind of information. And I would put ROS1 as a partner here too. So why do we test for EGFR? We test for EGFR mutation because we have an important first-line therapy available for our patients. There are a lot of options, but I think the preferred one based on a phase 3 trial that shows overall survival benefit is osimertinib. So if you have a patient, you detect an EGFR mutation, a sensitivity EGFR mutation like exon 19 deletion or exon 21 mutation, you should start an EGFR TKI. There are a lot of trials that have been performed using different EGFR TKIs, first, second generation, all of them show an increased response rate and increased disease-free survival. But we also have a third generation drug approved, osimertinib, that was compared to first generation drugs. And this trial, the FLORA trial, showed an increase in overall survival and a significant increase in disease-free survival for the patients that were exposed to third generation drug. The most important data, one of the most important data coming from this kind of drugs is the central nervous system response, the brain mets response, because these patients, they have a lot of brain mets over their history. And these drugs can penetrate well the brain and they can treat, and they have the same efficacy as they have in the systemic disease in the brain. So these are the data, has a ratio of 0.47 that is comparable to the patients that have not brain mets. And now we have new data coming up from initial disease. The ADORA trial was recently published and presented. The ADORA trial included patients with initial non-small cell lung cancer patients that were submitted to surgery, stage 1B through 3A. They could have received chemotherapy as adjuvant treatment, and they were treated with osimertinib for up to 3 years after finishing chemotherapy. And we have disease-free survival data, positive, very positive disease-free survival data, has a ratio of 0.17 for stage 2-3A disease. And this was highly significantly. We don't have overall survival data. I don't know if we're going to have it in the future. So this is a very point of debate in the oncology community now, if you're going to adopt an adjuvant treatment based on disease-free survival. But the point is, it's approved in the US, approved now in Brazil, and we are discussing with our patients this strategy, which means that we have to test initial disease patients too. Talking about ALK, ALK was one of the most well-developed target therapy, in my opinion, because it was fast, it was developed in the right way. And now we also have a lot of different drugs inhibiting ALK and second and third generation drugs. And we have all these options described in this guideline in NCCN. Alectinib is one of the options. And the data of alectinib compared to the first generation crizotinib drug shows again a disease-free survival that was very statistically significant, different from crizotinib. And the most important information as I mean is that this is a drug that can penetrate the brain. And the patients got a high rate of response in the brain too. And all patients, they also have a lot of brain mets during the disease. And this is the curve that shows the benefit in the CNS. And we have a long-term follow-up of this patient. We get very happy when we see that in year 5, we have 62 patients with metastatic disease alive, compared to 45% of the patients alive that use crizotinib. A lot of patients do, but it's even better when you look at alectinib compared to crizotinib. We are talking about a median overall survival that was not reported yet, compared to 57 for crizotinib patients. And it's a very a well-tolerated drug. Not a lot of AEs with this drug. As alectinib, you have brigatinib, that is another second generation drug, and we also have the same results. What I want to show you here is that these results are very consistent, they repeat it, and they are confirmed with other drugs, and brigatinib is one of them, and now lorlatinib is another drug. And lorlatinib is not only a third generation drug that can be used as first-line therapy, but we also have data, this is the CROWN trial, show the same data, very similar data to alectinib, but we also have data for resistance. When ALK patients, they get a resistance for the first-line drug they are using, like for instance, alectinib, brigatinib, we can expose these patients to other ALK inhibitor. Lorlatinib is one of the options. Now we are trying to recognize the type of resistance these patients develop. So it's the future of target therapy is testing all over again the patients in order to recognize what type of resistance they are developing and developing more target drugs to defeat resistance. ROS is another example of target therapy that's very important. All patients should be tested for ROS before starting treatment. And we have different drugs too, entrectinib, crizotinib, ceritinib, and even lorlatinib. And what I want to call your attention for us that it was approved based on a phase 1/2 trial that based on response rate, but it's a high response rate. It's a rare disease. So all the world approved ROS inhibitors based on an outcome that is used for phase 1 and 2 trials, but it's okay. And some drugs we are seeing this happen. And as you can see, high response rates for this drug. And even if the patients fail to the first-line therapy, for instance, with crizotinib, we can give lorlatinib, for instance, for these patients, and they start to respond again. Not all the target therapies are used in first line, always in first line. There are some downloads with different target therapies, like for instance, BRAF. We're still not sure if based on response rates, we can preclude chemotherapy or even immunotherapy. And we are not sure if this patient should receive BRAF inhibitors first line, with MEK inhibitors first line, second line. So still there are a lot of questions regarding the sequencing of some target therapies. But the message is we have to test in order to find these alterations. So I want to conclude my presentation, show you in a picture that I think explains it all. This is where we only had chemotherapy, not testing patients, not individualizing treatment, overall survival 8 months, and now I'm talking about more than 60 months of overall survival when we can select patients based on molecular alterations. Thank you for your attention.
Muchísimas gracias por la invitación. Soy Patricia Rivera, neumóloga en la Universidad de Carolina del Norte, y mi charla se trata sobre el tratamiento del cáncer de pulmón. In 2018, the TNM classification of non-small cell lung cancer was revised, and it was an important revision. It separated tumors by size, which was an important differentiation. But importantly, it also identified subgroups of patients within the metastatic stage category. We still consider lung cancer or group lung cancer into early stage, and by early stage, we are referring to patients who have T1, T2, N0, or N1 disease, locally advanced disease, patients who have stage 3A or 3B disease, and metastatic disease or stage 4. I'm going to briefly review some of the data on the standard of care prior to more recent advances in early stage lung cancer. The treatment or the standard of care for early stage lung cancer is surgical resection. But despite surgical resection, a significant portion of patients with resected 1B, and particularly patients with resected stage 2, those who have hilar lymphadenopathy, recur with distant disease. The concept was that there was micrometastatic disease distal that was not treated with only local therapy. Because the survival with surgery alone was relatively poor, many studies were done in the 1990s to look at the role of adjuvant chemotherapy, platinum-based chemotherapy, following surgical resection for patients who had been completely resected with early stage lung cancer. These studies in a meta-analysis showed that there was an advantage in 5-year survival, but the advantage was modest, about 5% improvement. Nonetheless, an important advantage, and this became the standard of care after resection for early stage lung cancer. But for over a decade, we remained at a plateau in terms of survival in early stage lung cancer following surgical resection. That changed recently with the explosion of the data on mutational analysis of non-small cell lung cancer, and we'll talk later, immunotherapy, and that there is a role for identifying patients with molecular targets, as described in the previous talk, that could benefit from more specific targeted therapies or individualized, personalized therapy. This is a study that looked at the role of osimertinib, a third-generation tyrosine kinase inhibitor, against the epidermal growth factor receptor in patients who had undergone surgical resection, had completed adjuvant chemotherapy, and then were randomized to osimertinib versus placebo. 682 patients who had undergone surgical resection for stage 2 and stage 3A. Not all received adjuvant, only 60% received adjuvant chemotherapy. Disease-free survival was the primary endpoint. Overall safety and overall survival and safety were the secondary endpoints. And it was an important study in that 24 months, 90% of the patients who had been randomized to osimertinib following adjuvant chemotherapy compared to placebo had a significant improvement in disease-free survival. Osimertinib was approved by the FDA in 2020 in the adjuvant setting of resected non-small cell lung cancer. More recently, the role of immunotherapy in early stage lung cancer was presented in the trial that randomized patients from 22 countries, 227 sites, who had completely undergone surgical resection for stage 1B to 3A non-small cell lung cancer. Following adjuvant chemotherapy, patients were randomized to the immunotherapy or immune checkpoint inhibitor atezolizumab versus best supportive care. Primary endpoints were disease-free interval for patients who had undergone treatment, but also to look at disease-free interval in patients who expressed programmed death ligand 1 in their tumors. This is the patients, so this is median disease-free survival in patients who had received atezolizumab versus best supportive care following adjuvant chemotherapy. And this is the group of patients who had a programmed death 1 overexpression, and this is the overall intent to treat group of patients. So this is important observation in that we're now improving, if you will, the 5-year the disease-free progression of patients with early stage lung cancer who receive additional therapies other than adjuvant chemotherapy. Stereotactic radiotherapy is an important intervention in the treatment of non-small cell lung cancer. It was first described in patients with early stage lung cancer who were not able to undergo surgical resection because of a poor underlying medical history or poor cardiopulmonary reserve. It is a reasonable intervention for patients who are also not willing to undergo surgery. They may have the pulmonary and cardiopulmonary reserve for surgery, but simply do not want to have surgery. It's revolutionized really the treatment options for early stage non-small cell lung cancer in patients who were deemed too high risk for surgery, because prior to stereotactic radiotherapy, we only had external beam radiotherapy to offer these patients, and survival was very, very poor. This is the first trial that looked at the role of SBRT in patients who were not able to go surgery, and demonstrated that at 3 years, the local control rate was 97%. SBRT has been looked at. The trials are very small in numbers in patients who are able to undergo surgical resection. In other words, is there a role for this therapy in patients who are fit for surgery? We have 3-year data from several trials. Again, most trials are quite small. There is one trial that's larger, but most of these larger trials are retrospective analysis. But nonetheless, we see an improvement in 3-year survival, an acceptable 3-year survival rate for patients who are able to undergo surgery, but choose not to have surgery, but rather SBRT. Moving on to locally advanced non-small cell lung cancer, these are patients who have metastatic disease to the mediastinal nodes, either the contralateral or ipsilateral nodes, stage 3A and 3B. For decades, the standard of care for locally advanced lung cancer had been either surgery or radiotherapy alone. And that was resulted in extremely poor survivals. In 2011, we had the first reports of data that concurrent treatment, particularly concurrent radiation and chemotherapy in patients with locally advanced non-small cell lung cancer resulted in improved 5-year survivals. Now, the 5-year survival improvement was not overwhelming, 15 to 20%, but it was certainly much better than the historical 5% 5-year survival with either surgery or radiation therapy alone. There are a subset of patients with locally advanced non-small cell lung cancer who are eligible for combined therapies that include chemotherapy and surgery. But the standard in most places in the United States has been concurrent chemotherapy and radiation. And while, again, this was incredibly important in that it improved 5-year survival and it became the standard of care, we had a plateau for many, many years in locally advanced disease without really the ability to move that 5-year survival forward. And that changed with the advent of immunotherapy. This was the first trial that randomized patients who had received concurrent chemotherapy and radiation therapy and were deemed to have no evidence of disease progression to receive adjuvant durvalumab, an anti-programmed death ligand 1 immune checkpoint inhibitor, versus placebo. Concurrent chemoradiotherapy followed by placebo had been the standard of care. The primary endpoints of this trial were progression-free survival and overall survival. Adjuvant durvalumab resulted in statistically significant improvement in progression-free survival versus placebo. It resulted in clinically meaningful overall response rate and a lower incidence of new lesions in the brain, because the brain is a site of recurrence. And as it was previously mentioned, systemic chemotherapy has poor penetration through the blood-brain barrier. So CNS disease is a very challenging recurrence for these patients. The update of this trial, the overall survival with durvalumab after chemoradiation therapy compared to placebo, was reported following that trial. And as you can see, improvement in overall survival for patients who had received adjuvant durvalumab. The grade 3 to 4 adverse events were really no difference between the two arms. A grade of 4.8 pneumonitis, however, was reported in the patients who had received durvalumab compared to concurrent chemoradiotherapy. And more patients in the durvalumab arm had to discontinue therapy due to adverse events. But nonetheless, an improvement in survival in locally advanced disease with immunotherapy, again, a significant change for after decades of having been at a plateau. But perhaps the most notable changes in the last 20 years in lung cancer have been the advances in the treatment of advanced stage non-small cell lung cancer. 20 years ago, when we addressed patients or managed patients with lung cancer, we had two important differences we had to identify. Is this squamous cell or is this adenocarcinoma? That was really the bulk of what we did because we chose chemotherapy drugs based on the histology. And that changed, but 10 years later, it was revolutionized because now we knew that a subset of patients with adenocarcinoma of the lung harbored specific molecular mutations that could be targeted and improve overall survival, overall response rates, and survival. By 2015, the landscape was changing even further with more targets being identified. And now by 2021, really, as previously mentioned, it is in the majority of patients with advanced non-small cell lung cancer that we can identify a target, not only a molecular target, but also a biomarker program death ligand 1, identifying patients who might benefit from first-line immunotherapy in the advanced stage setting. So incredibly rapidly moving, rapidly changing, and every year we expect newer and newer molecular targets to be found and newer drugs to be identified to treat those targets. This is the study, and it was already covered, so I won't spend more time, but this is osimertinib, again, a third-generation tyrosine kinase inhibitor in patients with advanced stage non-small cell lung cancer who harbor EGFR mutations, who have received no treatment, and randomized to osimertinib versus first-line tyrosine kinase inhibitors. Osimertinib had a more significant improvement in disease-free survival, in duration of response, but more importantly, in CNS disease. Again, very difficult because chemotherapy doesn't penetrate the blood-brain barrier. And this was a really important improvement in the survival of these patients. Osimertinib was superior in efficacy than the first-generation tyrosine kinase inhibitors. And alectinib has also been described. This was reported compared to crizotinib, which had been the first drug identified against the ALK mutation, and similar results and significant improvement and progression-free survival, particularly in patients with metastatic disease, comparing alectinib, a third-generation ALK inhibitor, compared to crizotinib, a first-generation. So dramatic pushing the envelope of improvement, not only disease-free survival, but also CNS disease, and that results in improvement in quality of life for many of our patients with advanced non-small cell lung cancer. As of 2021, we have 10 molecular targets that have been identified in non-small cell lung cancer, starting with the EGFR mutations in 2003 to the most recent KRAS G12C mutation, for which targets have been identified and commercially now available in patients with advanced non-small cell lung cancer. And in 2016, of course, the program death ligand 1 overexpression, which identifies subset of patients who can benefit from first-line immunotherapy. And as mentioned earlier, patient selection for targeted therapy depends on identifying the molecular and diagnostic biomarker. So it is imperative that patients, all patients with adenocarcinoma, undergo evaluation for molecular biomarkers, and all patients with adeno and squamous cell carcinoma, this is regardless of sex and smoking history, be tested for PD-L1. This is a paper that was published last year in the New England Journal of Medicine, and it looked at the effects of the advances of therapy on population mortality from lung cancer. And it was really important because it noted that you can see the significant improvement in reduction in mortality, more notable in men than in women, But you see this really important cutoff here in 2013, from 2013 to 2016, a much more dramatic reduction in mortality from lung cancer in men and in women. Why is that? Well, likely because of the targeted therapies. That benefit in survival could not be applied to screening because screening was very early. I mean, it was first approved in the United States in 2014, and not to immunotherapy, which were first approved in 2015. It was really attributed to the identification of the EGFR, ALK, ROS, and treating patients with targeted therapies. Another significant evolution was the introduction of immunotherapy to the paradigm of non-small cell lung cancer. The mechanisms of action relevant to lung cancer include central versus the peripheral. The central includes CTL4, cytotoxic lymphocyte antigen 4, which is expressed on T lymphocytes, and it downregulates T cell function. So binding antibodies will reverse that downregulation and augment the immune response to cancer. On the peripheral level, T cells express program death 1. Program death ligand 1 and 2 are expressed by either the cancer or the tumor antigen presenting cells. And when the ligand binds to the receptor, that down regulates and turns down or turns off the T cell's ability to fight cancer. So blocking that ligation is critically important in order to augment the immune response against cancer. Understanding or identifying, I should say, patients who express program death ligand on tumors is very important because that helps us select patients who would be best served with first-line therapy with immunotherapy compared with what had been the standard of care, which was chemotherapy. This is the first study to look at pembrolizumab versus chemotherapy for patients with program death ligand overexpression in non-small cell lung cancer. Estimated overall survival at 6 months improved in patients receiving immunotherapy first line. These results were updated in 2018, showing at 24 months a significant improvement in disease-free survival for patients who had received pembrolizumab compared to chemotherapy if they overexpressed PD-L1. And pembrolizumab was approved for first-line therapy in advanced non-small cell lung cancer in overexpression of PD-L1 in 2016. More recently, atezolizumab has been studied as a first-line agent in patients with non-small cell lung cancer. In this study, 574 patients with metastatic non-squamous or squamous cell who did not express EGFR or ALK mutations were randomized to atezolizumab versus platinum-based chemotherapy. Overall and progression-free survival were the primary endpoints, as well as evaluating patients based on PD-L1 expression. And as you can see in these curves, improvement in survival, 6-month survival and 12-month survival in patients who had been randomized to atezolizumab compared with systemic chemotherapy. And more notable, this is a notable difference in patients who have high or intermediate PD-L1 expression. Atezolizumab was recently approved for the first-line treatment of patients who express PD-L1 in their tumors and with metastatic lung cancer who express PD-L1 tumors. So again, pushing the envelope further and further in terms of overall improvement. Important to note that for patients who don't have overexpression of PD-L1, particularly squamous cell lung cancer, which are not likely to have a mutation, a molecular mutation. We have not yet found mutations that are meaningful in squamous cell lung cancer. The combination of chemotherapy and immunotherapy is important because chemotherapy may stimulate anti-cancer immunity by inducing immunogenic cell death and releasing more tumor antigens, which can activate dendritic cells. It can also eliminate immunosuppressive cells, and it can increase the ratio of cytotoxic lymphocytes to regulatory lymphocytes. This study looked at the combination of pembrolizumab and chemotherapy versus chemotherapy alone. And it's important to note that there was a response across all patients who expressed PD-L1, even those who had less than 1% expression. The benefit was seen again across all levels of PD-L1, but more importantly, without an increase in the frequency of chemotherapy-related adverse events. So for a subset of patients who are not fortunate enough to have a molecular target or to have overexpression of PD-L1, the combination of chemotherapy and immunotherapy has significant promise in terms of improving disease-free survival and overall survival. And this has been shown for both patients with adenocarcinoma of the lung and for patients with squamous cell carcinoma of the lung. What does this all mean? Well, it was discussed in our previous lecture. When we think about overall survival of non-small cell lung cancer over the last 25 years, when we only had second-generation drugs, we hoped for 5% 2-year survival. We never talked about 5-year survival. Even with third-generation chemotherapy drugs, gemcitabine, paclitaxel, docetaxel, you can see that the 2-year survival improved. We were hopeful for 15, maybe at most, but we were not talking about 5-year survival. Even with the monoclonal antibody bevacizumab, there was no hope of ever seeing patients alive at 5 years with metastatic non-small cell lung cancer. Targeted therapies changed that landscape. And this is older data, and I'm sure that will be much better now with third-generation targeted therapy agents. But with first-generation TKIs, gefitinib and erlotinib, we began to see patients with metastatic lung cancer alive at 5 years. And with immunotherapy, and this is second-line immunotherapy, this is nivolumab after patients treated with chemotherapy, 16% 5-year survival. And more recently, 5-year overall survival in patients who had been treated with pembrolizumab was reported. And as you can see, I'm sorry, let me just go back. For patients who had been treatment naive, estimated 5-year survival of 23%. And when you stratify based on PD-L1 expression, a significant better in patients who overexpress PD-L1. But again, we're talking 23% 5-year survival in patients with metastatic lung cancer, unheard of 10 years ago, 20 years ago. Importantly, we often think about all of these advances in non-small cell lung cancer, particularly because of the molecular targets which have been identified in adenocarcinoma. And we forget that 15 to 20% of all lung cancers diagnosed each year are small cell. And this is a disease that has a very, very poor prognosis. 60% or more of these patients are diagnosed with advanced stage small cell lung cancer, where survival, even 2-year survival is dismal. The role of immunotherapy is changing the landscape in patients with small cell lung cancer. This was the first study that explored the role of atezolizumab, or an immunotherapy agent, in addition to chemotherapy in extensive stage small cell lung cancer. 403 patients with extensive stage were randomized to receiving standard of care, carboplatin etoposide versus carboplatin etoposide plus the immunotherapy agent atezolizumab. And this was the first study to show an improvement in overall survival at 12 months for patients with extensive stage small cell lung cancer. Again, for more than 30 years, that survival curve had been plateaued. And here we have now evidence of making progress toward improved overall survival for about, a significant portion of patients who present with who are diagnosed with non-small cell lung cancer. There was more adverse events in the atezolizumab group compared to the placebo, but none of the patients, there was no increase in death. The complications of death were the same in both arms. So in summary, that without doubt, the last 20 years have revolutionized the care of patients with non-small cell lung cancer, with significant advances across the entire spectrum of cancer care, surgery, minimally invasive surgery, SBRT, advances in adjuvant therapeutics, advances in patients with locally advanced disease, and the role of immunotherapy and targeted therapies against molecular markers clearly has changed the landscape of metastatic non-small cell lung cancer. And we haven't even, seen, I think, the benefits of screening and detecting cancers at an early stage, and that was described by our first speaker, really changing that stage shift from more early stage cancers to and less patients with advanced disease. But without doubt, it is critically important to, especially in patients with early stage and advanced stage disease, to evaluate tumors for molecular characterization, to perform PD-L1 testing in all patients with advanced non-small cell lung cancer, that we can continue to push the envelope of personalized therapy in lung cancer to improve overall survival in these patients. Thank you very much.
Buenas tardes, muchas gracias por la invitación. Realmente es un honor estar compartiendo esta sección con los invitados que acaban de hablar. Bueno, mis conflictos de interés. Vamos a hablar un poquito de lo que es toxicidad por el tratamiento dirigido de inmunoterapia. Como sabemos todos, en los últimos años ha avanzado, y como ya explicaron muy bien las doctoras, los tratamientos, pasamos de tener solo quimioterapia hace 20 años, a tener a partir del 2009 terapias dirigidas con pequeñas moléculas y específicas y con muchos cambios en la sobrevida, y a partir del 2015 terapia dirigida de inmunoterapia específicamente, lo cual aumentó más la sobrevida. Estas terapias, sin embargo, tienen efectos adversos diferentes, en algunos casos mejores, en otros casos peores, y que tenemos que conocer porque no son similares a la quimioterapia estándar. Entonces, cuando hablamos de terapia dirigida específicamente, tenemos muchísimos receptores, mutaciones y drogas nuevas, de las cuales ya se han explicado. Yo voy a hacer hincapié principalmente en los inhibidores del EGFR y de LK, y de inmunoterapia. Cuando hablamos de inhibidores de EGFR, sabemos que tenemos inhibidores de primera, de segunda y de tercera generación. Los imatinib, que es inhibidor de tercera generación, tiene una irreversible, covalente, y es específica para la mutación del T790M, que resulta inactiva para los otros dos inhibidores, y es la primera elección en inhibidores actuales. Como sabemos, ya desde hace muchos años, erlotinib fue una de las primeras drogas que se empezó a utilizar, y tenemos muchos datos acerca de los efectos adversos que puede llegar a haber. Este estudio de más de 10.000 pacientes japoneses de non-small cell lung cancer y resecables recurrentes y avanzados, reclutó gente del 2007 al 2009 de 1.027 instituciones, con un seguimiento promedio de 12 meses o hasta discontinuación del tratamiento, y ellos se encontraron en primer lugar que tenían un 21% de pacientes mayores de 75 años y un 25% de performance status 2 a 4. Eso lo remarco porque habla de estudios de la vida real, y habla quizás de cómo es la toxicidad en la vida real y no en los estudios para aprobación de fases. Ocurren en estos casos, lo más prevalente fue, como ya sabemos, el rash y la diarrea, y lo que es enfermedad intersticial difusa se dio en el 4.3%, y específicamente en toxicidad grado 3 o más en el 2.6%. Lo relevante de esto es que además la incidencia de toxicidad pulmonar fue bajando en el transcurso de las semanas en las que fue indicándose el tratamiento, con lo cual uno puede prever que si en las primeras 6 a 8 semanas no se generó toxicidad, las chances son mucho menores posteriormente. No son 0, pero son mucho menores. La mortalidad en este estudio reportada fue el 35%, de los 429 casos, el 35% falleció. Y en los factores de riesgo que estuvieron desarrollados al desarrollo de enfermedad intersticial difusa fue enfermedad intersticial previa, EPOC, la consistencia de infecciones, la historia del tabaquismo y el poor performance status. Dentro de estos pacientes que tuvieron toxicidad, el ECOG, performance status elevado, la consistencia de panalización y la extensión a nivel del pulmón fueron los 3 factores que predisponieron a peor evolución. Dentro de las formas de presentarse, opacidades en vidrio esmerilado fue lo más frecuente, neumonía intersticial aguda con consolidación y vidrio esmerilado también fue presente, y también están descritos casos de neumonía en organización. ¿Qué ocurre con los segunda y tercera generación, como afatinib y osimertinib? Bueno, son bastante similares los reportes, hay menos datos, pero los reportes más o menos auguran entre un 3, 4 y un 7% según la droga y según las series publicadas de toxicidad pulmonar. ¿Qué pasa con los ALK? Bueno, hay algunas series que reportan grados menores de toxicidad, como 2% de toxicidad global y 1% para grado 3 y 5. Sin embargo, hay series más recientes en las cuales esta última evaluó 250 pacientes entre el 2015 y 2018, de los cuales 11 pacientes desarrollaron toxicidad pulmonar, 5 estaban con tratamiento con crizotinib, 5 ceritinib y 1 alectinib. Esto representa el 4% de toxicidad pulmonar, y lo relevante es que en este estudio, por lo menos, el tiempo de presentación mediana de la toxicidad fue mayor, que fue alrededor de los 5 meses. Las formas de presentarse también: neumonía en organización, opacidades en vidrio esmerilado difusas, y la coexistencia de neumonía intersticial aguda, que es la persistencia de áreas de vidrio esmerilado asociado a áreas de consolidación y la afectación bastante difusa. En este caso también los factores de mal pronóstico fueron la presencia de metástasis extratorácicas y la coexistencia de tabaquista o extabaquista. Este último estudio compara en la práctica clínica países de Estados Unidos países de Europa con Estados Unidos, en tratamiento principalmente con crizotinib y erlotinib. Para el inhibidor de la ALK, que es el crizotinib, la neumonitis se dio en una incidencia de aproximadamente 65 por cada 1000 pacientes año en los países europeos y del norte de Europa, y 275 en Estados Unidos. Y en el erlotinib fue similar, 75 por cada 1000 pacientes años y 312 en Estados Unidos. Hay diferencias, seguramente tengan en relación a que hay muchos pacientes que se presentan en forma asintomática y quizás no todos los protocolos de detección son similares, y bueno, es una de las explicaciones de por qué esas diferencias. Este es un hombre de 71 años con adenocarcinoma de pulmón, estadio 4, que inició tratamiento con erlotinib. A los 3 meses de tratamiento, como ya se veía, tenía comorbilidades, extabaquista, EPOC, y desarrolló en el área de enfisema un área de vidrio esmerilado difusa que era bilateral, a predominio del lóbulo superior derecho, y con áreas de fibrosis, ¿sí? Se interpretó que era toxicidad por erlotinib, se suspendió el tratamiento, se inició tapering con corticoides, y tuvo franca mejoría a nivel clínico del laboratorio de función pulmonar, y imaginológicamente, con el transcurrir del tiempo, siguió mejorando. ¿Qué pasa con la inmunoterapia? Como todos sabemos, la inmunoterapia, digamos, la inmunidad celular para combatir el cáncer está en fino equilibrio entre la identificación y erradicación de los antígenos extraños versus suprimir la respuesta inmune descontrolada. Y en este mecanismo es que interfieren de la unión de la célula dendrítica con el linfocito T citotóxico, el CTLA4 con el B7, y la unión de la célula tumoral con el linfocito T citotóxico. Esas dos uniones son uniones que inhiben y disminuyen o hacen un downregulation de la actividad inmunológica frente al cáncer. La inmunoterapia viene a bloquear estas uniones, ¿sí? El anti-CTLA4, ipilimumab, y anti-PD1 como el nivolumab, pembrolizumab, y anti-PL1 como el durvalumab, lo que hacen es bloquear estas uniones desarrollando una mayor respuesta inmunológica y por lo tanto una mayor respuesta inmunológica no solo al cáncer, sino también a predisposición a efectos tóxicos inmunológicos. Como sabemos, no se utiliza solo en cáncer de pulmón la inmunoterapia, hay muchas otras opciones de tratamiento, entonces nos encontramos en el futuro con un montón de pacientes que van a desarrollar toxicidades, no solo con cáncer de pulmón, sino con cánceres renales, melanomas y demás, y que pueden desarrollar toxicidad pulmonar. Dentro de las formas de presentación son muy variadas, lo más habitual es neumonía intersticial, pero pueden estar descriptos derrame pleural, reacciones sarcoidales, reactivaciones de tuberculosis, neumonías en organización, distrés y hasta cavitaciones pulmonares. Hay condiciones de riesgo que predisponen a esto, como es el tipo de neoplasia, las drogas que se utilicen, los tratamientos concomitantes y las comorbilidades. Dentro de las drogas, esto es un metaanálisis en el cual evalúa 17 estudios de cáncer de pulmón, melanoma y cáncer renal, en la cual encuentra una incidencia global de 2.7 para el desarrollo de neumonitis asociada a inmunoterapia, y cuando se hizo un estudio de subgrupos de solo los pacientes que tenían cáncer de pulmón, encontraron que la incidencia fue mayor de 4,1, con lo cual en este estudio por lo menos la incidencia de toxicidad inmunológica fue mayor para los cánceres de pulmón que para los cánceres de otro tipo. Cuando comparamos diferentes tipos de inmunoterapia, tenemos los anti-PD1, que en los estudios que se han aprobado, el porcentaje de neumonitis fue alrededor del 4%, los anti-PDL1, que fue aún menor el porcentaje de neumonitis, y al comparar los diferentes tipos de drogas, lo que podemos encontrar es que, bueno, además de las reacciones cutáneas, gastrointestinales y artralgias, que son los factores más frecuentes de toxicidad por inmunoterapia, la toxicidad pulmonar fue mayor, tanto para el grado 1 y 2 de efectos adversos, como para el grado 3 y 5, con los anti-CTLA4, que con los PD1 que con los PDL1. Entonces, el tipo de droga determina también qué tipo de inmunoterapia, qué tipo de toxicidad puede llegar a generarse. Cuando comparamos monoterapia con combinación de dos terapias inmunológicas, también encontramos una mayor chance de tener reacciones inmunológicas. ¿Qué ocurre con la radioterapia? Bueno, se sabe que la radioterapia coexiste con la inmunoterapia con un efecto booster mutuo, en el cual la radioterapia predispone a un mayor efecto de la inmunoterapia a nivel local y viceversa, y también hay algunos estudios que describen que podría llegar a haber mayor predisposición a neumonitis. Sin embargo hay otros en los cuales se ha comparado pacientes con y sin radioterapia, que están bajo tratamiento con inmunoterapia, y no se ha encontrado diferencias, con lo cual es algo que todavía sigue en estudio. Los pacientes que tienen enfermedades autoinmunes previas tienen mayor posibilidad de desarrollar afectación toxicidad inmunológica. Generalmente son afectaciones leves, requieren estrecha vigilancia y un abordaje multidisciplinario. Los pacientes con afectación pulmonar previa, no solamente inmunológica, sino EPOC, tabaquistas y demás, o pacientes con reducción de la reserva pulmonar, son pacientes con mayor riesgo y deberían ser evaluados también en forma multidisciplinaria. Estos son los tipos de presentación de la toxicidad inmunológica. ¿Sí? Se puede presentar también como manifestaciones en vidrio esmerilado, como compromiso intersticial, con engrosamiento reticular vivasal, neumonía en organización, símil criptogénica, pues en realidad sabemos que no es criptogénica, pues está desarrollada por inmunoterapia, neumonitis por hipersensibilidad, ¿sí? Con engrosamiento reticular, el patrón de los 3 grises de vidrio esmerilado, atrapamiento aéreo, y el compromiso peribroncovascular, y patrones indeterminados. El tiempo de presentación de la toxicidad por inmunoterapia es variable, es aproximadamente 3 meses, pero puede variar, y hay casos en los cuales se ha desarrollado hasta 2 años posteriores. Entonces, para resumir, el tiempo de aparición es entre 2 y 24 meses, con una mediana de 3 meses, y con una resolución con el tratamiento que va alrededor de entre las 5 y las 6 semanas. Dentro de los grados de neumonitis tenemos grado 1 y 2, que son grados más leves y mejor tolerados y generalmente tratados en forma ambulatoria. Se retrasa la administración de la inmunoterapia, se puede o no iniciar con tratamiento con corticoides según la gravedad del cuadro y según la extensión del cuadro, y posteriormente resuelto el proceso se puede reiniciar con la inmunoterapia. Grado 3 y 4 son grados más severos en los cuales uno ya tiene que pensar suspender definitivamente la inmunoterapia o inmunoterapia también se aplica para los inhibidores de terapia dirigida. Siempre planteamos la duda de cuál es el rol de la broncoscopía, la biopsia y el en estos pacientes. Está claro que en algunos casos hay que diferenciar y descartar procesos infecciosos. La biopsia quizás no tiene una utilidad todavía marcada, salvo algún cuadro muy puntual en uno quiere descartar alguna otra patología, pero si no, no tiene una indicación de rutina. Hay diferentes protocolos de manejo de estos pacientes. Lo que tienen que quedar claro es que estos pacientes tienen que poder evaluarse previamente y determinar cuál es el riesgo para poder definir cómo seguir a futuro. Este es un hombre en enero del 2020, 54 años, con cáncer pulmonar estadio 4, avanzado, desde el 2016 en tratamiento con inmunoterapia, que en enero nos viene a ver con dificultad respiratoria progresiva, sin fiebre, se suspende el nivolumab, tenía eosinofilia de 8%, se realiza una broncoscopía con un acúmulo de eosinófilos en el VAL, se interpreta neumonía ionosilófila, empezó tratamiento con deltisona y resolvió todos los infiltrados nuevos. Posteriormente, en diciembre, reinicia el tratamiento por progresión de su enfermedad y vuelve a repetir la inmunoterapia, con lo cual debió suspenderse definitivamente. Nosotros en nuestro centro, de 12 pacientes evaluados en el último año y pico de inmunoterapia, tuvimos un solo caso de neumonitis. Para el escaso número que tenemos nos da un 8% de prevalencia, pero son pocos números como para tener una conclusión clara. Para terminar, tanto la quimioterapia estándar como la inhibidores de tirosina como la inmunoterapia pueden desarrollar neumonitis, tienen formas de riesgo diferente, tienen formas clínicas de presentación similar y todas deben tratarse con esteroides, todas deben suspenderse la medicación y reevaluar en qué situación se puede reiniciar o no. Los pacientes con comorbilidades previas tienen mayores chances de tener toxicidad pulmonar que los que no la tienen. Y para concluir, la toxicidad pulmonar, tanto por inhibidores de EGFR como LK, es variable, si bien se reporta que varía entre el 4 y 8%, los estudios que se ven de la vida real reportan porcentajes mucho más elevados. La mortalidad reportada sí fue del 30%, la presencia de enfermedad intersticial previa y el pobre performance status son predisponentes de toxicidad. No hay diferencias significativas entre los diferentes tipos. Respecto a la inmunoterapia, sabemos que los efectos más comunes son gastrointestinales, cutáneos y articulares. Sin embargo, la neumonitis, si bien es poco frecuente, en algunos casos puede llegar a ser grave. Deben evaluarse los pacientes al inicio del tratamiento para detectar cuál es el paciente que puede tener mayor predisposición a generar la toxicidad. No está claro, no está definido cuál es el rol de la broncoscopía, hay que evaluarlo en cada caso particular, y es fundamental el rol del neumonólogo junto con el oncólogo, y el manejo tiene que ser multidisciplinario porque son patologías que son pulmonares y que no pueden ser evaluadas solo desde el punto de vista de una toxicidad del tratamiento, sino que hay que considerar toda la base previa del paciente. Bueno, muchas gracias.
Muchísimas gracias a todos, de veras, fue una presentación sumamente actualizada y nos da datos de cómo podemos manejar esta enfermedad, que ya la estamos volviendo cada vez más crónica y cada vez dándole más tiempo a poder tener terapias más dirigidas, con menos efectos adversos y con mejores resultados de morbimortalidad. Desgraciadamente, por tiempo no vamos a poder estar haciendo preguntas el día de hoy, pero tenemos preguntas que se les estará mandando, y ustedes en forma sincrónica en la audiencia pueden mandar sus preguntas escritas y se las estaremos dirigiendo a los ponentes para que podamos tener respuestas en forma asincrónica. Muchísimas gracias, Karen, por la organización, de veras excelente, y espero que se sigan gozando el Congreso y se sigan cuidando mucho. Pasen un buen día. Muchas gracias. Gracias a todos.
Gracias a todos. Estaremos en contacto.